Thank you very much, Mr. Chairman, ladies and gentlemen. First, I would thank Professor Nassef, Professor 𝗖𝗏𝗍𝗏 to give me the privilege to be here. And sorry, and I apologize for being online, but yesterday it was impossible to reach Cairo by plane. My topic is hostile aortic neck, definition and safe management strategy. These are my disclosure regarding the endovascular treatment of aortic disease. And when we speak about the treatment of the aneurysm, we can define first the diameter of the aneurysm, but it's very important to define even the quality of the neck and the quality of the iliac arteries. Then for aortic repair, when we have to treat patients, we have to define different morphological aspects. One of the main problems is the quality of the neck. If you look to this paper published in 𝗔𝗍 regarding the classification of the aortic neck according with the length, diameter, angle, calcification, and thrombus, they find that 4 different categories of the aortic neck. If you look to the first 3 categories, you can see that we are in line with the eye view of the endograft that we can see in this slide. And when we are inside of the eye view, generally, if you look to the literature, it is impossible to have good results with low percentage of graft-related adverse event. Then this is the reason that in the daily practice, there was an increase of percentage of endovascular treatment of aortic disease. But the problem is not in type 0, 1, and 2. I think if we have to decide EVAR or open, the problem is when we are speaking about hostile neck, severe or type 3 lesion. In these patients with this lesion, the endovascular treatment have an increase of adjunctive procedure, an increase of type 1 embolic in the perioperative period, and if you look to in the follow-up at 1 year, and then we have an increase of aneurysm-related mortality at 1 year. This was supported even with this recent paper published at the Massachusetts General Hospital from Boston, with an increase of type 1A embolic long-term survival if we compare patients that are inside or outside the ICU. If we look to the different quality of the hostility, you can see that the first one is the length, and the length less than 1 centimeter. If you look to the literature, in patients with a neck length less than 1 centimeter neck, we have an increase of early type 1 and late type 1 in the leak. And according with the Jan presentation, in this recent paper, you can see that if you look to the follow-up, there is an increase of mortality if you compare EVAR of IFU and open repair. Then if we have to define the safe management strategy for short aortic neck, we can see to the European guidelines. In the European guidelines, we can see that it is possible to decide between open or a complex endovascular repair according with the patient status, anatomy, local routines, team experience, and patient's preference. In the number 96 recommendation, these guidelines reported that fenestrated stent graft should be considered the preferred treatment option, and in some patients it's possible to use parallel graft or endostaples. If you look at patients with neck diameter more than 28 millimeters, we reported our experience in 2017 in 𝗔𝗍. We reported an increase of embolic type 1A reintervention in follow-up of our patients. And if we look to this systematic review and meta-analysis recently published in 𝗔𝗍, you can see that in patients with a large diameter infrarenal neck, we have an increase of any reintervention, an increase on aneurysm-related procedure and migration. Regarding the safe management strategies in patients with our wide aortic neck, we don't have any support from the guidelines. And in our daily practice, in my activities, in my center, we generally use first open repair and second endo with fever if the neck angle is less than 60 degrees, and the EVAR plus endostapler in other cases. If you look to the patient with severe neck angle, in these patients, this recent review of the literature reported that we have no difference regarding mortality-related mortality, abdominal aortic cannula rupture if you compare severe angulated neck with no severe angulated neck. But there is a very important difference between the two groups in terms of type 1 endo-leak and reintervention follow-up in favor of the no severe angulated neck. We recently reported in the annual meeting of SBS in Boston our experience. We defined that we have no differences between the two groups if you compare freedom from reintervention, but the survival in patients with angulated neck was lower if you compare with patients without the angle. In the same time, we defined that in patients with angle more than 90 degrees, there is a high risk of neck-related reintervention and late endo-leak type 1A. In patients with angle more than 60 degrees and length less than 1 centimeter, an increase of reintervention in the perioperative period, a decrease of survival of patient follow-up. And when we have angle more than 60 degrees and diameter more than 28, we have an increase of neck-related reintervention and an increase of late endo-leak type 1A. Again, even for the angulated aortic neck, we don't have support regarding the modality of treatment, support from the guidelines. So we don't have guidelines regarding the angulated aortic neck. And this is our daily practice in my center. We generally reported the choice between open repair, EVAR, standard EVAR, or EVAR plus stapler, or FIVAR, according with the neck angle, the diameter of the neck, and the length of the neck. And this is absolutely in line with this 𝗙𝗵𝗀𝗀 consensus that we published in Annal Vascular Surgery in 2020. It was a 𝗙𝗵𝗀𝗀 consensus from Italian group of vascular surgeons, and they support the opinion that one criteria alone is enough to discourage standard of EVAR. Then we think that it's very important to define the correct treatment of hostility on the abdominal aortic cannula with hostile neck, according with 2 or more criteria of hostility. And with this approach, we can define the best choice between open repair, endo. In endo, we can define the different choice like FIVAR, like parallel graft, like EVAR plus endostapler. Thank you very much for your kind attention.